Once a patient reaches remission, how do doctors decide between monitoring for relapse and starting maintenance therapy?
So in AML, we have a risk calculation. So it's mainly based on the genetic abnormalities of the AML, the karyotype, which we mentioned, that's the chromosomal abnormalities, and some mutational abnormalities that can place patients in one of three categories: either favorable risk, this would be about a quarter of patients would have actually a good prognostic leukemia, AML, that would portend that they would respond very well to just chemotherapy alone, and most of those patients may be cured just by chemotherapy. Then there are some of the unfavorable ones we talked about. Those patients will not be cured by chemotherapy alone, and we usually would recommend a stem cell transplant. That's another quarter of patients. And actually, most patients, 50% of patients, fall in this intermediate risk, and we use some of the genetic markers to stratify them then. So again, this FLT3 ITD, it's about a third of patients overall in AML will have that mutation. And it's been shown in many studies that is associated with a higher risk of relapse. So those patients would be ones we may suggest, of the intermediate risk, we might suggest a stem cell transplant. I would say the standard of care these days is to observe after remission induction and consolidation, observe, and especially like a favorable risk patient. That's still our standard, I would say, is to observe those patients for relapse. However, if you had a higher risk of relapse, that may be a patient, again, post the consolidation, because we know that that's much better than just a maintenance strategy. So getting the consolidation, and then after that, that would be a type of patient I might recommend to consider maintenance. Again, even better if they can do it on a clinical trial. That way we can compare it and learn from that.
So usually when we're making a decision is actually even before patients make it to complete remission. It's oftentimes when you get their early genetics and information of the characteristics of their disease. So acute leukemia can be set up in multiple buckets, the favorable risk and then intermediate or less favorable patients or adverse risk patients. For favorable risk patients, our goal really is to get them through a more intensive regimen and monitor them with surveillance, clinical surveillance. But for the less favorable or the intermediate risk patients, and anything above that, if they are not able to complete a more intensive chemotherapy regimen followed by allogeneic transplantation, those are the folks who benefit the most from a maintenance regimen to date.
Thanks for watching. By creating a HealthTree account, you can get exclusive access to the latest HealthTree University content, track your course progress, take quizzes, and bookmark lessons. Visit the links in the description below to get started.